Today we operated on a 3 case of the Sellar parasellar lesion that no one of them was pituitary adenoma, and we are talking a lot about many cases of Sellar and parasellar, but these 3 cases have 3 major information that worthy of translation to young physician and neurosurgeon, and we will review them briefly. The case 1 was a young girl referred to us with the failure to thrive, no other clinical scenario. Yes?
Delayed puberty.
Only right eye visual disturbance that her mother said us that this have been from the many years ago. No progressive visual disturbance, a stable visual disturbance of the right eye, no diabetes insipidus, but a low T3, T4 level, and the failure to thrive, and the patient had a primary amenorrhea. In evaluation, they found the Sellar lesion, and the Sellar lesion are very interesting. So you should see this. This is a coronal MRI view with the gap. This is the pituitary gland enhancing this view. And there is something here like an adenoma. This is look like an adenoma. Mesoadenoma, meso, not so large, and this is a classic MRI that we have. But on the T2 and on the flare view, we have a different signal observed inside the Sellar with the large Sellar. And you see here on the sagittal gap, there is unusual, again, view. Something that very interesting was the CT scan. You see on the CT scan there is calcification inside the Sellar. The calcification inside the Sellar. Well, in operation we found now Dr. Akbari, our ENT colleagues, exposed the whole sphenoid, and we are inside. I opened the dura, and on opening of the dura, we found this yellowish material comes out. This yellowish material, like a fibrinoid change, is seen in the some adenoma also. Some adenoma that had bleeding inside them. After many years, they can look like a giant aneurysm inside. You know, inside the giant aneurysm, you see also the fibrin. And it looked like this. We have seen in many cases of adenoma the fibrinoid material that end up from the hemorrhage. But when we go there, we see that I remove this material. You see this material, and after evacuation, I search for the calcification. This is the calcification, venous to diaphragm. This is diaphragm Sellar. And the calcification adhere to the base of diaphragm, and I remove it. You know, you see this calcification. This is something that we see inside the craniopharyngioma. Therefore, I have seen many cases of craniopharyngioma with failure to thrive, and later with DI. This case maybe was intrasellar craniopharyngioma. This is pathognomonic of craniopharyngioma. Therefore, craniopharyngioma can present it in children with failure to thrive and not with the diabetes. And the next case is again very interesting case. Dr. Akbari will tell about the symptoms and what we see.
This is our patient, a 6-year-old boy with the anisotropia on the right eye.
Please tell us about the anisotropia.
It means the direction of the both eyes are not in the same way. On the right side,
it's a kind of strabismus, yes? Yeah. When we have not a fixed eye to perceive objects, and there is esotropia, exotropia, we call it anisotropia.
It's It seems that there was a medial rectus palsy in the right eye, and interestingly, in the evaluation, we found a very interesting isosignal intensity in the right sphenoid and ethmoid area, and at the same time we had a next one a signal void area exactly at the with the isosignal intensity in T1.
This is very interesting view. You see the signal inside the sphenoid and ethmoid. It look like sinusitis, and this view is good. This view. You can see here the signal change in the sphenoid sinus. This is the signal in a sphenoid. This is the midline picture. This is a bone of a child that is hypermerode, and this is the adenoid. This is the adenoid, and this is signal change in the maxillary sinus bed. And you see in the next slide, you can see here I put this view.
As you see, this is the sphenoid sinus. We had a peripheral severe edema of the mucosa and a signal void intensity in the center of the sphenoid, which is pathognomonic for the mycetoma or fungus ball of the sinus. So we did endoscopic transsphenoid surgery. We encountered a severe edema, mucosal edema of the sphenoid and the ethmoid area, and had biopsy. We hope this proves the situation of the right eye of this patient.
Therefore, fungus ball or inflammatory fungal rhinosinusitis can cause extraocular nerve muscle palsy. It's different from the fungus infection. We should mention here for medical students.
It was not an invasive fungal sinusitis. It was only mucosal edema with no bony invasion or no vascular invasion. It is totally different from the invasive sinusitis. It especially occurs in the immunosuppressed patient. Our patient was not immune compromised, and we assumed that it was only fungus ball of the ethmoid and sphenoid sinus.
Therefore, in the case that you see the fungus ball and you rule out every other case of extraocular muscle palsy from the neurologics and other class, there is a reason to go there and clean and remove the fungus ball from the sinus. And the most important agent is the Aspergillus fumigatus, if I remember
Fumigatus
correctly.
and nigra, yeah.
Aspergillus is the most common cause. The third case was a boy, 21 years old, presented with the
hyponasal and nasal obstruction in the left side. This was very interesting.
It is very unusual case again. We see a patient with the hyponasal speech and nasal obstruction. An evaluation, they found a skull-based tumor that filled every aspect of the nasopharynx, and this is the MRI that the patient referred to us. And this is the tumor, filled every part of the posterior to septum. This is the nasal septum, maxillary sinus, every cavity of the nose, between the turbine, everywhere is filled with the tumor, and the tumor goes down to the near of the jugular foramen and invasion to clivus. And preoperative imaging, the most common cause that of this pathology maybe is chordoma and chondrosarcoma. but the presentation was very interesting. The patient present with the hyponasality and nasal obstruction.
This is the reason of the patient's hyponasality and or nasal obstruction. As you see, this mass is completely closed. The posterior corona of the left side of the left side, yes, the left side. This area is the soft palate. You see, it is completely pushed frontward. This mass is totally closed the nasopharynx in the left side and right side.
And the whole clivus is involved and distracted.
And you see that this is the upper and the middle part of clivus is completely destroyed.
And it is very interesting. This clivus don't push backward. Why? Because the tumor goes inside the nose. If the chordoma or other intraclival pathology takes time, they can go inside the brain and push the basilar and bones. We saw many more cases with intracranial invasion rather than seeing it goes into nose. But this case with a nasal obstruction is a very nice case that we have today. Today we go and remove the whole prevertebral tissue. We goes up to the disc of C2, C3. This tumor goes down inside the wall of the pharynx up to the C2, C3. And yes, it is very important to remove this because this patient will come back with the airway problem.
Yeah.
I saw many years ago 2 cases like this end up in tracheostomy, Because of this today, we are stressed to open the airway, This is the pituitary gland compressed upward, and we remove the whole clivus from carotid to carotid. But the most important thing is opening the airway. And know that if the chordoma goes inside the muscle, it got never be cured. Because soft tissue and chordoma are a mishap. There is no hope to cure it. We remove as much as possible, and the patient should receive the proton therapy. Therefore, today, if we want to recap or talking about, the first case was a craniopharyngioma in a prepubertal girl that ended up in primary amenorrhea and failure to thrive without hormonal change, without diabetes insipidus. It is a very rare scenario. The second case was a fungus called making a third nerve partial palsy in a 6-year-old boy. And the third case was a giant chordoma that the presentation was only nasal obstruction. It is very unusual that the chordoma doesn't go to distract the nerves or the vision and only come with the nasal obstruction. It is very rare. 3 rare cases of the parasellar pathology. Thank you very much.